Yeah, welcome to EASL Studio, your weekly hepatology broadcast. My name is Thomas Berg. I'm hepatologist from University of Leipzig and co-producer of the EASL Studio. And today we want to discuss with respective and very honorable experts, is it time to abandon the use of ultrasound in the surveillance of HCC in patients with steatotic liver disease, also called MASLD? And you know, we are recommending ultrasound as a main method to survey patients at risk for hepatocellular carcinoma. But the reality we're really facing since decades that it really doesn't work so well, as at least, depending on the study, but looking at it globally, more than 50%, perhaps even 70%, will not be diagnosed by surveillance, but just by chance, and then quite often in an uncurable stage of, say, HCC. And so far, we were confronted with the fact that we mainly had hepatitis B or C, so not large prevalence diseases in our population, so perhaps even easier to survey these numbers of patients. But now we are facing the situation that we have a global epidemic of fatty liver disease called MASLD. 25% of the population can be affected, and MASLD has become also a risk factor for hepatocellular carcinoma. And then we have the situation that people can be obese, and then there's a question whether ultrasound is really the best method we have. So I'm quite happy that I have really great experts that will help me to elucidate a bit on this interesting topic. And we know that the title of our studio is a bit provocative with whether we should abandon ultrasound, but nevertheless, I think there are good arguments that we want to see from our experts. So first of all, we have Professor Valérie Villegrain, and she's chair of the Department of Radiology at the University Beaujon Hospital and professor of radiology at the University Paris Diderot Sorbonne Paris. So welcome, Valérie.
Thank you.
It's great.
Very happy to be with you tonight.
It's wonderful that you are here. Then we have Professor Juanma Pericas, and he works at hepatologist at the liver unit Vall d'Hebron at the University Hospital in Barcelona, and also in the Institute of Research and the Department of Medicine. So Juanma, welcome to the EASL Studio.
Glad to be here. Thank you for the invitation.
And last but not least, we have Professor Tim Dennecke, and he's chair of the Department of Diagnostic and Interventional Radiology at the University of Leipzig here in Germany. Welcome, Tim.
Hello, I'm happy to be here, and thank you for the invitation as well.
So perhaps, Juanma, we can start with you, whether you can give us some background information. If you look in the literature, we see there are more and more publications really dealing with the issue of MASLD-associated hepatocellular carcinoma, and to make things even more complicated, in cirrhosis and non-cirrhosis. So what are really the concerns? What are the numbers? Can you give us some dates on the incidence rates and what we are really seeing here?
Yes, of course. Thank you, Thomas. I mean, this is a really thrilling topic because we are at the crossroads of epidemiology and the models of care that we need, and a clinical problem that might be, of course, shared with our radiology colleagues. But we are, on the one hand, using some epidemiologic data that we don't know whether they really confers a real picture in our clinics. So it's everywhere in the world experiencing the same epidemiological picture, but because systematic reviews and meta-analysis tell us that the incidence of HCC related to MASLD has tripled in some settings in the last 15 years, which is very concerning. Of course, we always have the concern of whether this is an information bias. Are we looking more thoroughly to our patients and therefore
And if you say it has tripled, does it mean it has tripled in those with cirrhosis, or is it overall? What do you think?
That's a really good question. It has tripled overall in several settings, mostly in the Anglo-Saxon sphere, where is precisely where most studies have pointed out to a worryingly significant incidence in non-cirrhotic patients, where perhaps a third of cases might occur in non-cirrhotic patients.
Yeah, so this is a huge number, given the prevalence of fatty liver disease we are seeing around the world. So can you give the pure incidence rate that is calculated or that has been seen in both either MASLD with cirrhosis and without?
Yes, of course. We still need better data in terms of the resolution, but what we know is that the overall incidence for cirrhotic patient is between 0.8 and 2.3, 2.4 percent annual, which is similar to what we saw in viral hepatitis, a little lower perhaps. Whereas in the non-cirrhotic population, it ranges between 1.3 and 2.3 per thousand patients per year. So it's much lower. However, there are some studies pointing a much higher incidence in certain settings. So this still needs some further validation. And of course, there are some overlapping epidemiological aspects such as alcohol consumption and the rates of metabolic comorbidities that might have to do with these different rates we are.
Yeah. Well, man, thank you so much. Perhaps from a practical point of view, both to you, Valerie, and then Tim, do you see more patients now with steatotic liver disease associated hepatocellular carcinoma in your tumor boards in your daily practice? Has it changed if you compare it to the last 10 or 20 years? Perhaps Valerie, you first.
Okay, yes, definitely. We used to see mostly HCC in patients with chronic liver disease, advanced fibrosis or cirrhosis, but now we see more and more patients with metabolic syndrome, patients with steatosis, and with minimal or even no fibrosis developing HCC de novo. Absolutely.
Yeah. Can you give an estimate of the number or the percentages of patients that are you're treating or you're taking care of in your unit that has non-cirrhosis MASLD associated hepatocellular
I think it's a difficult
carcinoma?
question.
Yeah.
I would say something like overall, taking into account all HCC patients, I would say 10, 15%.
Yeah. And Tim, what do you think?
I think it's a difficult question because at the same time, you're asking for 10 and 20 years, the awareness of fatty liver disease and the HCC risk is increasing. And now we ask in a different way on the origins of the cirrhosis, if it's really alcohol related or was it a different origin. And with the progress of cirrhosis, the steatosis of the liver decreases again. So we don't see it very much in the MR when it's a MASLD related cirrhosis and it developed an HCC inside. So sometimes you can't even measure the fat inside this liver anymore when it's cirrhotic.
Yeah,
So
but that you see HCCs in those without cirrhosis, so with a
cirrhotic.
yeah.
I think yes. It's not a huge number, but I think it's more common to see those non-cirrhotic patients.
Yeah.
If I can add very quickly, Thomas,
Yeah.
these worrying numbers are even more worrying because we are not screening systematically most MASLD patients. In fact, according to recent meta-analysis, we are screening about 25-30% of our patients. So what would happen whether we will doing a complete and thorough workup to all fatty liver disease patients?
Yeah.
And as a consequence, these non-cirrhotic patients usually have much larger tumor than the others.
Yeah. No, and I also asking sometimes myself, that we are now perhaps diagnosing or made a diagnosis of MASLD or MET-ALD. So this means a combination of both, but this is quite recent according to the new nomenclature of many patients that has been previously defined as alcohol-related liver disease, right? because then ask, well, you drink a beer per week, and then we calculated it might be much higher. So perhaps there's also a kind of, by better definition, a kind of a diagnosis bias. Would you agree? But nevertheless, if I summarize what you said, that you also feel that perhaps liver cancer on the basis of steatotic liver disease, whether it's just metabolic plus alcohol, or alcohol related, is currently perhaps really the most prominent underlying disease in liver cancer. Would you agree? Or do you still see a lot of hepatitis B or C or other, let's say, autoimmune genetic disorders, let's say, in your countries? This means Spain, France, and Germany.
I think your suggestion is right, at least spoken for our Central European region. There's a shift. Yeah.
Absolutely, I agree.
Yeah. Well, we had a recent guideline coming from EASL, a CPG on metabolic dysfunction associated steatotic liver disease and MASLD, and there are also certain recommendations on how to deal with this population and what are the surveillance strategies. And I can read the first recommendation that carcinoma HCC monitoring programs should be applied to individuals with MASLD-related cirrhosis as a strong recommendation. But then, as a third bullet point, it's written that ultrasound-based surveillance has a low sensitivity for the detection of HCC, especially at an early stage, and especially in adults with MASLD-related cirrhosis, because of BMI factors that are associated with this. And they also recommend that then alpha-fetoprotein can be combined with ultrasound. But perhaps starting with you again, Juanma, what is really the situation in ultrasound surveillance? How do you see it in your practice? Is it working? How do you deal with these patients, and do you add alpha-fetoprotein in all of them?
Yeah, well, in my routine clinical practice, I might say that we have had some surprises in early detection with ultrasound. Of course, we lack robust data because most studies on HCC surveillance do not come from MASLD patients, but from viral hepatitis. So what are we applying those lessons thoroughly to our regular practice? I'm not so sure about that. And we have diagnosed in recent years more and more non-cirrhotic HCC that were not under surveillance. So what was important for me is to read in those guidelines that the topic of AFP was brought up because this was already included in prior American guidelines, whereas the latest European guidelines from 2018 did not mention on an individual basis to consider AFP. So this is the first time. And I think this opened an interesting window regarding personalized risk that we can discuss further. But of course, using ultrasound is not perhaps the perfect undertaking in this setting.
Yeah. Do we have, perhaps to our colleagues from the radiology departments, do we have data on, let's say, how the visualization of the liver is if you use ultrasound, especially in this population? And what are the visualization limitations? Are there data that can be cited or quoted about this issue? Tim, would you like to start?
I think there are multiple papers on that issue, and one is a more recent one. I think it's from Korea, from Huang, and it's nicely compared in. It's from San Diego. Is that right? Yeah, Huang from San Diego, and they compared an early non-abbreviated MR protocol with ultrasound and the screening. And what they did is they analyzed how many patients were poorly visualized inside the liver, so HCC might have been overlooked. There was, in the regular ultrasound screening, there was 1/3 of patients with severe impairment of image quality, And in the MR group of an abbreviated MR, it was half of that, it was only 1/6. So that underlines that there are some patients which are nicely to be examined with ultrasound, maybe 1/3. And in the rest of them, it's getting difficult. You need more time. And in some of them, you don't even see the entire liver because it's hidden behind bowel loops. You have a lot of ascites or reflections due to heterogeneity or steatosis inside the liver.
Yeah. So Valerie, but with the poor visualization, of course, quite often we get in our records, if we get the ultrasound back, that the quality was high, low, but I think it's not really written how well ultrasound has been performed and how many percentages, let's say, of the liver could be screened. What do you think? And is it realistic, or do you have experience with this, that we should really introduce the quality of the visualization in our surveillance strategies?
Absolutely. I think it should be mentioned in every ultrasound report. If we talk about surveillance, surveillance in a classical cirrhosis is already more difficult than on a healthy liver because of the heterogeneous pattern of the liver. And then with MASLD patient, we add an extra difficulty, which is presence of steatosis and high BMI. And for sure, we should absolutely evaluate the quality of exam. Actually, this is strongly suggested by the LIRADS ultrasound, which is semi-quantitatively assessed. I'm not sure that we can really give quantitative data, but we can say, I have been able to explore the entire liver from the very superficial to the very deep areas, or I have had limitations. And for sure, the patients where we have strong limitation on ultrasound, we should do something else.
Yeah, well, I think that's quite clear, and a kind of recommendation really coming here from this panel, that we should have a better documentation of really the quality of what we are doing, and then to define what can be done further. And in the guideline, I mentioned the CPG on MASLD, there is this recommendation that then cross-sectional imaging by MRI may be undertaken in selected adults with a high risk, being at high risk with persistent poor visualization at ultrasound, and then particularly in individuals with dysplastic or regenerative nodules. And this sounds logical in a way, but I ask myself, well, if ultrasound is not working so well, how can you see whether there's a nodule dysplastic or whether there are regenerative nodules? And could this be then easily seen in MRI? Perhaps, Valerie, you first.
Indeed, MRI is far better than CT and ultrasound to depict changes in the liver texture, and especially micro-regenerative nodule, macro-regenerative nodule, and even dysplastic. We used to have really strict definition according to signal intensity on T1 and T2 between these. Now we know that, especially with the use of hepatobiliary contrast agent, we can really clearly define the benign nodule, what I would say, from the nodule at risk for HCC. And indeed, ultrasound is probably the poorest imaging modality to detect and characterize the regenerative nodule.
Yeah. So, Johanna, do you use MRI in your clinical practice in this situation? Are you following this recommendation if there's poor visualization? And we will come later on how perhaps to best define high-risk patient, but for the moment we can leave it. So if you have a high-risk situation and a poor quality ultrasound, do you go directly for MRI?
Well, not directly, but after a first report reporting poor visualization, the equivalent of LIRADS 3, we will go for an MRI. Problem is that we don't get systematic reports with the LIRADS scale, so we need to contact the radiologist and ask him or her, what do you mean with poor visualization? Where are we standing in this particular patient case? But yeah, of course, in those patients that either because of morbid obesity or other causes that poor technical visualization, we will go for MRI over CT in these cases, yes.
Yeah. And Tim, would you agree that CT doesn't play a role here in this setting, that really then the next step as recommended in the guideline is an MRI?
Yeah, I agree.
Sorry. I would choose MRI over CT if possible. Yeah. But you have to keep in mind in patients with a large ascites or something, image quality in MRI can be poor. So some of the patients have to be prepared for that.
Can I say something, Tom?
Yes, please, Valerie. Yeah.
If we compare the diagnostic value of CT and MR to diagnose HCC, they are roughly the same. I mean, MRI is slightly superior. But if we talk about screening and surveillance, this is another story where MRI is far better.
Yeah, and I think if you really go to the literature, it's really interesting that more and more paper coming up dealing with this situation, realizing that surveillance that we are currently doing is not sensitive enough and so on, perhaps also specificity, and they're going for what is called these abbreviated MRI strategies. And they are non-contrast abbreviated with contrast agents. And so could you please update us? What does it really mean? What is the difference between a full MRI with contrast agent or these abbreviated regimens? How long are they? Is it feasible? Can this be implemented? Valerie, if you like to
with pleasure.
This question. Yeah.
So abbreviated MR means a fast MR. Usually I would say 10 minutes in and out of the room. So we have to select the best sequences. If we go to the non-contrast, we will pick the T1, the T2, and the diffusion weighted sequence. And then if we go to contrast, and we can discuss the added value of contrast, we will use either with the extracellular contrast agent, the dynamic phase, which are the phases that we usually use to diagnose HCC, arterial phase imaging, portal venous phase imaging. And last, if we use the hepatobiliary hepatospecific contrast agent, then we will not look at the arterial or portal venous phase. We will perform the primary injection outside of the MR room, and then the patient in the room will have T2 diffusion and post 20 minutes post-contrast sequence, T1 sequence. So the objectives are completely different.
Yeah. So perhaps this is a good time also, Tim, to ask you, what are really the differences in these contrast agents and what can we learn? So we have a hepatocyte or a hepatobiliary contrast agent, and we have an extracellular one. So what they are doing and what kind of information do we get from these different contrast agents?
So when we talk about intravenous contrast agents, we could compare the one which is given for computed tomography, for ultrasound, or the regular one, the extracellular contrast agent for MR, because all those three visualize the vascularization of the liver and the tumor. And they try by contrast enhancement, make it possible to depict hypervascularized lesions like an HCC. And then in MR, you have the additional opportunity to give a liver-specific agent, which is also gadolinium-based. And first, when it's injected, you have the similar dynamic behavior when it runs through the vascular system. But then the liver starts to take it up into itself. So there's a hepatocellular specific uptake of this contrast media, making the liver bright on T1 weighted images. And the tumors, also the HCC or metastases, stay dark because they do not have the capacity to take specifically up this agent. That's how it works. But as always, nothing is 100% in medicine, and especially hepatocellular lesions can behave differently in some cases.
Yeah. And Valerie, could we get even more information about these contrast agents, especially the hepatobiliary one, also in terms defining severity of liver disease. We learned now it depends on the receptor in the OTP that takes a contrast agent into the hepatocyte. So is there more information we can get from using these contrast agents?
Sure. So the hepatospecific contrast agents use non-specific transporters, which is the OTP B1, B3, that are also used for drugs to enter hepatocyte. And then they are excreted through the bile. So first, it may give information also on HCC and HCC subtyping. This is the first thing, because not all HCC will behave the same. And as Tim has said, 90% of HCC are hypointense on the hepatobiliary phase, but there is a subgroup, quite interesting, that shows overexpression. But we can also look at the background liver, the surrounding liver, and to assess the liver function or to correlate with the liver function, which is also interesting because it gives you a non-invasive assessment of the liver function, which can be interesting for staging.
Yeah, and when you mentioned subtyping, does it have really clinical implication? Can you say that this is a more, let's say, less differentiated tumor or linked to prognosis?
Absolutely. First, it is related to tumor differentiation, higher differentiation, higher uptake, and also in the subtypes now that are well identified, and especially the beta-catenin subtypes, using the Wnt pathway, there is an overexpression of these transporters, and this subtype is interesting to know because it's less proliferative as the other one, and it may or may not, because all the papers do not agree, have an impact on patient management. But I think it's interesting to know.
Yeah. Juanma, how do you use MRI in your center and together with your radiologists? And are you using which kind of contrast or already these abbreviated technologies, or if ultrasound from the visualization point of view is not sufficient, go you to a standard full contrast?
We're not using abbreviated protocols that I'm aware of yet. There's also disclaimers. Many of our patients that have either advanced fibrosis or cirrhosis, they are recruiting in clinical trials, either intervention or not. They do receive repeated imaging, including MRI, in a regular basis. So screening is done in an alternative pathway to the regular clinical one. But yeah, we're using the same contrast that both Valerie and Tim mentioned. And particularly for these plastic nodules, we have been using gadoxetate enhanced contrast for a long time. And we have been very comfortable in that scenario for a while. But we've seen a spike on MASLD related HCCs in our tumor committees recently. So there's been a lot of discussion of whether this might have some special implication. We haven't moved yet from one scenario to the next one, but this is an ongoing discussion yet.
Yeah. So I think to summarize our discussion so far, I think it has become clear from all these studies that perhaps, especially in the muscle situation, ultrasound works less well as perhaps in other situations, you know, slim people from Asia with hepatitis B or so on. And that perhaps all the different forms of MRI, is it correct whether it's an abbreviated one with or without contrast agent, in this situation add a lot of information in terms of identifying at-risk populations, early HCC, dysplastic nodules, or so on. Would you agree, Valerie and Tim?
Absolutely, I would agree. If we look at the data comparing if we should use contrast agent or perform non-contrast abbreviated MRI, I think there is still room for research, because actually these data are not real data. They have not been evaluated in really at-risk population. They're more simulated population or simulated protocol. Yet my feeling, but it's a personal feeling, I think if we want to increase the sensitivity, I think we should use contrast agent.
Yeah. What do you think, Tim?
Yeah, my opinion is very similar to Valerie. Most of the studies, or I think all of them, are hypothetically, so only retrospectively selecting certain sequences from the entire MR protocol and then comparing them with each other. And that is not really reflecting the real world. The real world doesn't mean only, well, would I call this nodule now for a recall and a full MR or not? It is also a forensic one. If you think of lawsuits in radiology, they happen most of the time in the breast cancer screening program. So this is a very sensible topic. So if we put the patient into the MR and we would have the chance to make a full MR, what is the basis to argument that we can leave out certain sequences which we know of that they are very powerful in detecting disease? And if we leave them out, we might overlook the lesion in this very individual patient, and this may cause problems not only because of the patient, but also as I said.
Yeah. No, I think that's an important point, and thanks for raising this. Perhaps we can come back in a minute to this point again. But Juanma, I think now it's all about for whom really we should go for MRI. We have seen about the visualization with ultrasound, but that's perhaps not the whole story. And I was impressed by a recent paper you published together with international experts about risk stratification in patients with MASLD. And it was published in Clin Gastroenterology Hepatology this year, and was also a reason why I was so happy that you joined the session to give your experience. So what is the concept of this risk stratification? How can this be done?
Thank you, Thomas. That's kind of you. Of course, this is just a concept. It has to be put down to earth in many settings. Yeah, but what we know is that probably there's a spectrum of risk MASLD associated HCC that has not just to do with whether a cirrhosis is well established, but with the phenotype regarding metabolic risk, together with the well-known other factors such as smoking and alcohol consumption. So how do we create a gradient where we can place a specific patient to decide the HCC screening strategy from the moment they are diagnosed? Of course, this might be dynamic because patients are not static and they may change their, I don't know, obesity-related comorbidities and other things. But what we do know is that beyond the genetic risk, that is very specific for MASLD HCC according to recent data, which is still preliminary. What we need to assess is whether a patient is, roughly speaking, very inflamed, whether the inflammation adds to the advanced fibrosis, therefore creating a risk that is much similar to cirrhosis or even higher. So perhaps a patient might merit MRI screening before cirrhotic if everything together leads to such conclusion. So this is the general concept.
So you mean that would be a concept especially also for those without cirrhosis, because with cirrhosis we do screen anyway, or we do surveillance anyway, am I right? Or
yeah, from what we know as of now and from the recommendations of the recent guidelines, I wouldn't care so much now to go in whether HCC cirrhotic patient need to be screened, and whether we know that, well, this need to be systematic screen. We have all the discussion regarding what happens with the early visualization and this limitation. This, regardless of the other factors, if they are cirrhotic and they do not have good visualization on high BMIs or severe obesity, might need MRI sequences, of course.
And to give some examples, you mentioned genetics. These are the typical genetic risk factors associated with ALD and MASLD, so PNPLA3, MBOD, TM6, SF3, and these.
Yeah, but beyond those, beyond PNPL3, TM6, SF2, there are some studies pointing that, for instance, the SP21.1 locus that modulates cyclin D1 has been associated, particularly in pre-cirrhotic patients, with a higher risk of HCC. There are others, the TER promoter, the CTNBV1. So this does not limit itself to the well-known genetic risk factors. Of course, we need to go beyond that in order to leap and use this in clinical practice. And beyond genetics, we know that epigenetics are very important as well. There are some scores that already include epigenetic-related markers such as circulation tumor DNA methylation markers, such as the LAMP score and others. This has been already proposed in several publications. We are not still there yet in order to apply that, but there are studies underway that might result very helpful in terms of how to use this practically in the clinical setting.
Yeah, I think this is very interesting because it could mean that we come to the point that we also screen a certain or do surveillance in a certain population less often, but being more intense in the really high-risk situation, and then going perhaps directly also for an index MRI or to see the structure of the liver, whether there are nodules or not. But the main argument, and then coming to our radiology colleagues again, is that if you talk about these MRI surveillance, they say, well, it's too expensive, it's from the capacity not possible, and so on. But there are also recent data and also cost effectiveness analysis that perhaps speak a different language. So is it really true that we can't go in towards this direction? Or you mentioned, Valerie, 10 minutes in, out. This seems not too complicated, perhaps also not so expensive. So I would really get your opinion from both of you, Valerie, and then Tim. What do you think about? Is it feasible? What about cost effectiveness? You know, if you are really able to detect at an early stage, curative stage, and perhaps you have one really optimal surveillance instead of quite often suboptimal ones. And also ultrasound is not without any costs if you look how much time for the investigation you need. And it's normally a very trained physician that should do this. How would you discuss this or respond?
I think
to this?
it's a very difficult question. I am always very cautious looking at cost effectiveness studies because it varies so much from one country to another one. So I have read the paper from Thailand. This is interesting. I don't know, or I'm not sure we should extrapolate the results. This is the first thing. And indeed, if we increase the number of abbreviated MR, we will have to change the workflow of MR, which is far, far from that now. The second thing beside cost effectiveness is availability. And again, it varies a lot from one country to another one. But still, in many European countries, it's difficult to get an MR from abdominal indication. And this is probably even the major limitation compared to the cost effectiveness.
Yeah, and Tim?
Well, I think the cost drivers here are mostly in the ultrasound case, the physician time, because at least in Germany, it's done by physicians and not technicians. And it takes a while to examine a liver really well on ultrasound. You need at least 10 minutes, I would say. And then you have the recall costs for maybe lesions, to have them clarified by MR or even with biopsy. And then the false positives costs and the costs of overlooked lesions, which are far more expensive to treat when they get palliative. And on the other hand, MR time is expensive. To run an MR, not even considering the costs of buying it, is not cheap. And you need physicians, you need technicians, which are hard to find. Sometimes it's harder to find a technician in large cities than an MR. And many radiologists know now from what I speak, at least in Paris, it seems to be similar when I look at Valerie's face. So this is a bottleneck, an extreme bottleneck. And we shouldn't believe that, especially with abbreviated MR, we would get rid of the recalls and the overtreatment of false positives. Now, they will be there. And in a real life study, you would have them. If you look only on retrospective data, they probably by bias are not so heavily seen in the study results. And then you would have to make the cost effectiveness analysis again in your proper country.
Yeah. Thank you so much. I think we need to come to a kind of an end or summary, but then also have a very brief look into the future. So we said our studio session is called, "Is it time to abandon the use of ultrasound in steatotic liver disease and HCC surveillance?" So Juanma, what do you think? What would you answer after having this discussion?
I mean, if I were to provide a very straightforward answer, I should say no. We're still not there yet. We need more data. Of course, the field is moving rapidly. We will be seeing hopefully a very different scenario when every piece is put together, both in terms of the epidemiology data and the cost effectiveness analysis that they were mentioning, because we need local information in order to adapt these studies. And of course, there's a big leap between cost effectiveness and cost utility, how we can apply this in real life. But
Yeah.
I think we need to tend towards an alternative, because we have identified a really concerning spot that if we multiply this as a really public health issue, will be very, very costing in terms of morbid mortality, because we will start seeing not only decompensated patients, but a lot of HCC diagnosed late, which already happens.
Yeah, so Valerie, for you, Miss, more specifically, should we abandon ultrasound in a specific at-risk population?
No, I don't think so. But we should better know the imaging quality of ultrasound. Let me be a little provocative.
Sure.
When the liver is fatty, it becomes bright on ultrasound. And if you have a patient where you can scan completely the whole liver, you are even in a better situation than in a healthy liver, because the lesion to liver contrast will increase. So I think this is very important. And in that setting, ultrasound is great. In another setting where the attenuation, the liver attenuation related to steatosis increase, and we are not able to see the deepest part of the liver clear, we should stop ultrasound. I would say as fast as possible. No need to spend 20 minutes, because actually in 2 minutes, you will know if you scan very well the patient or not. So we should, I think, really stratify on liver ultrasound, and maybe also on other factors, clinical factors, biological factors. But the first stratification on ultrasound, it's feasible now.
Yeah. No, that's great. And Tim, perhaps again, and another step, if you then do an MRI, let's say with contrast agent, would this help as a kind of an index investigation to then further stratify your follow-up evaluation, whether you really need MRI, whether could MRI in this sense help, that you just have one and then decide how you should go further?
I think it's still a bit experimental, but if you think of MRI and its abilities to analyze liver texture and inflammatory processes by DWI, or maybe liver function, it might be a perfect first test on the diagnosis of a parenchymal liver disease to assess the risk of the disease itself and of the risk to develop HCC. And if you think of dysplastic nodules verified by contrast-enhanced MRI, or even with hepatospecific agents, you could, in these patients, or maybe one step further, in more patients like these, identified not visually, because it's not possible, but by the help of artificial intelligence. And thereby you would define this very specific high-risk population among your usual screening patients. And in these, I would go for intensification of the screening process with at least yearly a full diagnostic MRI. But there's another point, which is maybe even more important, is the awareness of the possibility to get the screening. I think this is the largest end where we can save patients, to get them in any screening program, even if it's ultrasound.
That's absolutely true, and this is really a major issue, and perhaps something for another studio session. But you already mentioned AI, and this will be my last question to the panel. It's a bit to take an outlook to the future. Where are we in 5 or 10 years, and how all the different methods, more risk stratification issues, using of AI, you mentioned the liver texture, also ultrasound can be used to implement textural pixel box strategies that can be seen by AI. So Juanma, what do you think? Where are we in 5 years in terms of this big challenge of HCC risk in the large population of MASLD patients or patients with MASLD?
Yeah, my personal hope is that in 5 years' time, we are really assessing the efficacy of machine learning or digital twins or other AI-related technologies in clinical trials compared to the standard of care. Because if we are successful, we will be screening our patients better, and therefore the number of patients would be so much that we won't be able to do everything at our liver clinics. And so these need different settings and different participation. The more optimized and the better proven, the more successful we will be in terms of identifying patients at risk in early phases. So I think there are some ongoing studies. We are involved in a digital twin study assessing the HCC risk in patients with advanced fibrosis, and things look very promising. I don't have data yet, to be very conclusive, but I hope so. I hope we are utilizing these tools in the near future. Yeah.
Yeah, thanks a lot. And Valerie?
Same thing. I think we should define the high-risk patients who are not cirrhotics. And this is the challenge. And I'm sure that we will use all the possible tools, the genetics you have mentioned, the biological behavior, but also the imaging. You mentioned the MRI. I truly believe that it's very interesting to see changes in the liver texture that we cannot see with our eyes. But I also will rely with ultrasound, and we have ongoing studies that might give interesting results.
Yeah, and Tim?
Yeah, I think the strength of artificial intelligence is that it's independently reading out data which are from different scales. So it can be clinical data, scores, it can be proteomics, genomics, liquid biopsies, but it can also be imaging material to be read out. And the integration of all of these parameters, that is something which is, without artificial intelligence, very, very difficult. But that's probably the clue, to take all the parts together and to read them out.
Yeah, so thank you very much. And I think I want to conclude this EASL Studio session. I think we realized that with 25% of the world population having MASLD, we need really to think about how we deal with this situation. I think it has also become clear that we need a kind of a pre-stratification, and AI might help. Serum markers and others, and clinical markers, of course, age plays a role, whether diabetes is present, and Juanma all mentioned on this. And I think the good news is that there are prospective studies now running, evaluating it, and perhaps with this we will get to a kind of decision support tools that really could help us to come to a better risk stratification. And in my point of view, it must be a simple serum marker. We can't really survey these patients with whatever imaging technique, even with ultrasound. Perhaps it's not really feasible. So I thank you so much for joining, Valerie, Juanma, and Tim. It was a wonderful session together with you. I thank all the audience listening and watching to us. And I would like to say goodbye, but do not forget to become part of the EASL family and become a member. and stay tuned also with the other EASL Studio sessions that will be broadcasted quite soon. Thank you very much and goodbye.
Thank you very much. Goodbye.
Thank you. Goodbye.